So let's look first at acanthamoeba keratitis. The case study describes a university student, right? Red eyes, blurring, and pain that just keeps getting worse over weeks.
Yeah, this is a classic microbiology meeting, let's say, modern bad habits.
Okay, so what's the single most critical risk factor here? What's the entry point?
It's almost always the combination of two things: extended wear contact lenses
Which so many people use.
and poor disinfection protocols. We're talking about improper storage, using unsterile water, or even homemade saline solutions.
People make their own saline.
They do, to save money. But the critical risk, the one people forget, is showering or swimming while wearing contacts.
Because the amoeba is in the water?
It's everywhere.
Yeah.
Acanthamoeba is a free-living amoeba. It's ubiquitous in soil, in tap water, you name it. The lens basically acts as a vehicle to hold the amoeba against the cornea.
Like a petri dish strapped to your eye.
That's a grim but accurate way to put it. It allows the amoeba time to invade.
So what's the clinical red flag? Because, a simple red eye can be anything.
The red flag is the timeline, the Deloan progression.
How so?
A swift, painful bacterial keratitis develops over a couple of days. It's fast. This takes weeks or even months.
Wow.
The definitive sign, though it appears late, is the characteristic ring infiltrate on the cornea, if it's not caught and treated aggressively by then.
And damage is severe.
The initial pain and blurring progresses to severe inflammation, cataracts, and often permanent vision loss.
And what's the countermeasure against a free-living amoeba? You can't just throw penicillin at it.
Of course not. Standard antibiotics are completely useless. Initial treatment requires topical antimicrobials, things like miconazole and neomycin.
And that's often combined with something more invasive.
Yes, aggressive corneal debridement to physically scrape away and remove the infected tissue.
And I saw in the sources, in very rare cases, this can spread beyond the eye.
It's rare, but yes. In severely immunocompromised patients, it can move past the eye and cause a devastating, often fatal, granulomatous amoebic encephalitis in the central nervous system.
Speaking of immunosuppression opening the door, let's look at aspergillus. We had a case study detailing a patient with COPD using chronic corticosteroids who developed a serious pulmonary infection.
This is a perfect example of an opportunistic fungus just waiting for its chance.
So the two factors were the underlying lung disease and the drugs.
Yes, the COPD created damaged lung tissue, and the long-term low-dose corticosteroid use, which suppresses T-cell immunity, created the optimal environment for invasive pulmonary aspergillosis to take hold.
When this fungus establishes itself in the lung, what's the distinctive visual signature we look for on an X-ray?
It creates what we colloquially call a fungus ball.
A fungus ball.
Or an aspergilloma. It's a circular mobile mass of fungal hyphae, fibrin, and debris that forms within a pre-existing pulmonary cavity.
So a cavity left over from a previous infection, like TB?
Often, yes. And this mass isn't just sitting there. It can erode the surrounding tissue, which causes the patient to cough up blood. Hemoptysis.
Now, how do we fight this infection? The source material highlighted one drug that is famous, or maybe infamous, for its severe side effects.
We are definitely talking about amphotericin B.
Ah, yes.
It has the notorious nickname amphoterrible.
And for very good reason, I take it.
For a very good reason. Its mechanism is highly effective. It binds to ergosterol, a component unique to the fungal cell membrane.
So it targets something we don't have?
In theory. It essentially punches holes in the fungal cell. But here's a problem. It also has an unfortunate, though lesser, affinity for cholesterol in human cell membranes.
Especially in certain organs.
Especially in the kidneys.
So that structural similarity leads to massive collateral damage.
Exactly. The key side effects are severe fever, chills, arrhythmias, and most importantly, significant nephrotoxicity or kidney damage.
So managing the infection becomes a balancing act.
A desperate balancing act. How much amphotericin B can the patient's kidneys tolerate before the treatment itself becomes life-threatening?
Let's shift our focus to parasites that exploit a weakened brain, specifically Toxoplasma gondii. The case study here focuses heavily on HIV and AIDS patients.
Toxoplasmosis is the ultimate opportunistic brain parasite. It is the single most common cause of ring-enhancing lesions on a CT scan in HIV patients.
And there's a specific threshold for that risk.
A very precise one. The risk dramatically escalates when the patient's CD4 plus T-cell count drops below 200 cells per cubic millimeter.
And at that point, a latent infection can just wake up.
Precisely. An infection that many people carry asymptomatically can reactivate and become life-threatening encephalitis.
And remind us, where do these latent infections typically come from?
usually from the ingestion of oocysts. This is why immunocompromised individuals are cautioned about cleaning cat litter boxes.
Because cats are the definitive host.
They are. You can also acquire it from eating cysts and undercooked meat. What makes it so dangerous is that reactivation. The standard treatment for that active disease involves the synergistic action of pyrimethamine and sulfatazine.
Okay, moving down from the brain to the gut. The next few cases detail microbial warfare in the GI tract. Let's start with Giardia lamblia. Chronic, foul-smelling, fatty stools, weight loss. It just screams malabsorption.
It does. Giardia is acquired by ingesting cysts in contaminated water, the classic beaver fever you might pick up while camping.
And the parasite, it attaches to the intestinal wall, but it doesn't actually invade the tissue, right?
That's a critical point.
Yeah.
It doesn't invade. Instead, it forms a physical barrier on the surface of the gut and causes inflammation.
Which disrupts absorption.
Exactly. It leads to malabsorption of fats and vitamins, which results in those greasy, voluminous, foul-smelling stools, what we call steatorrhea.
Visually, under a microscope, Giardia is one of the most memorable organisms.
It really is. When you look at the trophozoid form, the active form, it's a motile, pear-shaped organism with 2 nuclei.
And it has that look.
It's often affectionately or perhaps humorously described as having a smiley face or an old man's face appearance.
Yeah.
You don't forget it once you've seen it.
The primary treatment for Giardia is metronidazole, which brings us to another fascinating mechanism of action. Why is this drug so effective against protozoa and anaerobes?
Metronidazole, which we use for a lot of gut infections, is actually a prodrug.
So it's inactive when you take it.
Exactly. It diffuses into the microorganism, but it only becomes active or reduced in the strictly anaerobic environment of the pathogen.
So our own aerobic cells don't activate it.
Right. It's a targeted activation.
Way.
Once it's reduced, it produces highly cytotoxic intermediates-free radicals that immediately shred the pathogen's DNA, killing it swiftly.
A very clever way to target the pathogen. But of course, it comes with that famous warning regarding alcohol.
Absolutely. The infamous desulfuramine-like effect.
And this is a serious reaction.
Oh, very. Metronidazole interferes with the breakdown of ethanol in the liver. So if a patient drinks alcohol while taking the medication, acetaldehyde, which is a toxic metabolite of alcohol, builds up rapidly.
And that causes
Intense nausea, vomiting, facial flushing, sometimes chest pain. It's a critical teaching point for patient safety. Don't mix them.
We transition now from the relatively benign gut to the blood, focusing on Trypanosoma cruzi, the agent of Chagas disease.
Chagas disease, which is endemic across the Americas, is transmitted by the reduvid bug.
Often called the kissing bug.
Yes, and why kissing? Because it bites painlessly, often around the lips or eyes, while the host is sleeping.
But the bite itself isn't what transmits the parasite.
No, that's the strange part. The parasite is transmitted when the bug defecates near the bite wound, and then the host unconsciously scratches the feces into the wound.
The acute phase of the infection has a very distinctive visual clue.
It does, the Romana sign. A unilateral, non-tender swelling around the eye, what we call periorbital edema.
But it's the long-term consequences that are truly devastating. It affects the nervous system.
The autonomic nervous system, specifically. The parasite destroys the ganglia, the bundles of nerves that control organ function.
And what are the organs most affected by this nerve destruction?
Primarily the heart and the GI tract. The nerve damage in the heart leads to life-threatening heart block and a progressive dilated cardiomyopathy, where the heart muscle severely enlarges and fails.
And in the gut?
In the digestive system, the loss of neural control causes the formation of megacolon and megaesophagus. The organs lose their motility and become massively dilated, making eating and passing waste nearly impossible.
Staying with blood parasites, let's touch on visceral leishmaniasis, also known as Kala-Azar.
This one is transmitted by a different vector, the sandfly. Kala-Azar is caused by Leishmania donovani.
And this organism is remarkable because it changes form depending on where it is in its life cycle.
It has a dimorphic nature within the host cycle, yes. In the human, it exists as the small, non-flagellated amastigote form.
And where does it hide?
It hides and replicates silently inside the host's own macrophages. It turns the immune cell into its nursery.
And the patient presentation is a severe systemic collapse.
Yes. It's characterized by severe spiking fevers, massive enlargement of the liver and spleenopatosplenomegaly, and a profound drop in all blood cell lines, which we call pancytopenia.
So how do you confirm the diagnosis?
You have to find those amastigotes inside the tissue cells. It often requires an invasive procedure, like a bone marrow biopsy or splenic aspirate.
Let's wrap up the GI tract with a brief look at Ascaris lumbricoides, the common roundworm.
Ascariasis is extremely prevalent worldwide, especially in areas with poor sanitation. The organism itself is quite large, and its life cycle involves a rather strange migration.
It doesn't just stay in the gut.
No. The eggs are swallowed, larvae hatch in the gut, but then they travel through the bloodstream to the lungs.
To the lungs.
Yes, they are then coughed up and swallowed again to mature fully in the small intestine.
And the classic diagnostic findings.
A very high eosinophil count in the blood, often exceeding 10 or 20% of the white blood cells, and of course finding the characteristic rough-surfaced eggs in the stool.
And what's the standard pharmacological weapon against these roundworms?
For nematodes like Ascaris, we rely on the bendamidazoles, so mebendazole or albendazole.
And what's their mechanism?
Their targeted mechanism is the disruption of the helminth's crucial microtubule synthesis. By paralyzing the worm's internal structure, it's weakened and eventually expelled from the host.
All right, now we need to spend some time differentiating the soil-transmitted worms that cause tissue migration. These present unique risks, especially in patients who are immunosuppressed.
Yes, and the hyperinfection cycle of Strongyloides stercoralis is particularly dangerous.
So what distinguishes strongyloids from most other nematodes?
The standard cycle starts like hookworm. The larvae penetrate the soil through bare feet. They migrate to the lungs, are swallowed, and mature in the small intestine.
Okay, that sounds similar so far.
But here is the critical difference. The hyperinfection cycle allows the problem to escalate internally.
Meaning it doesn't need to leave the body to reinfect?
Exactly. The infective larvae can mature and reinvade the host right there within the gastrointestinal tract, leading to a continuous, self-perpetuating infection cycle.
And this hyperinfection syndrome is extremely dangerous.
It is, especially in patients who are immunosuppressed. For instance, those on high-dose glucocorticoids. It can lead to disseminated disease. The treatment of choice is ivermectin.
Now contrast that pathology with the hookworm, so ancylostoma or nectator. Same entry, but a different primary outcome.
Right. While hookworms follow a similar migration path soil to lung to gut, their major pathology occurs in the gut itself.
How so?
They attach firmly to the intestinal wall and cause chronic, massive blood loss. The primary clinical consequence noted in the sources is severe iron deficiency anemia.
A microcytic anemia.
A microcytic anemia, yes, indicated by low ferritin and hemoglobin. So to simplify, strongyloids causes immune reaction and tissue invasion. Hookworm causes slow exsanguination.
Moving to a truly domestic annoyance, pinworm, Enterobius vermicularis. The life cycle is simple, but the transmission is relentless.
It's the most common worm infection in temperate zones, particularly among children. The eggs are ingested, so it's fecal-oral transmission.
And they mature in the colon.
Right. But the key behavioral feature, the one that drives the symptoms, is that the female worm migrates nightly to the perianal area to lay her eggs.
And that causes the intense, characteristic nocturnal itching.
The itching, yes. And that's what perpetuates the cycle. The child scratches, gets eggs on their hands, and then reinfects themselves or others.
And the diagnosis relies on a very low-tech solution.
The adhesive cape test. It sounds crude, but it's effective.
So
You apply clear tape to the perianal area first thing in the morning before bathing. Then you examine the tape under a microscope to find the eggs.
Simple but effective.
Very.
Now we have to address the helminths that form truly dangerous cysts in human tissues. Cysticercosis from the pork tapeworm and hydatid cyst from the dog tapeworm.
This is a critical distinction that often confuses people. Let's start with Tachynia soleum and cysticercosis. You get the adult pork tapeworm by eating undercooked pork. That worm lives in your gut.
Right.
You get the potentially fatal cysticercosis, the tissue and brain cysts, by ingesting the tapeworm's eggs.
So not from the pork itself.
Not directly, usually from fecal contamination from someone who harbors the adult worm.
And if those larvae invade the brain, what's the clinical outcome?
Neurocysticercosis. These cysts are a major global cause of adult-onset seizures. When the cysts eventually die and calcify, they cause a massive inflammatory reaction in the brain tissue.
And treatment must be very careful.
Extremely careful. It often requires surgical removal or a combination of praziquantel to kill the worm and steroids to manage the intense inflammation as the worms are killed.
And now the hydatid cyst, caused by Echinococcus granulosus, the dog tapeworm.
This is typically acquired from ingesting eggs found in canine feces. These cysts are very slow-growing, often in the liver.
And the core danger here is rupture.
Absolutely. If that cyst wall breaks, the contents, which are highly foreign to the host's immune system, leak out. A massive, potentially fatal anaphylactic shock. This risk means that aspiration of the cyst for diagnosis is strictly contraindicated. You do not stick a needle in it.
The treatment must therefore be handled very delicately.
It is.
Yeah.
It's a combination of pharmacological therapy with albendazole or mebendazole combined with surgical excision.
And sometimes they inject something into it first.
Yes, sometimes a controlled injection of a scolicidal agent like formalin before removal. This is specifically to kill the contents and prevent that anaphylactic rupture during surgery.
Finally, in this parasitic review, we have the filarial nematodes, which cause the horrific diseases elephantiasis and river blindness.
Let's start with Wuchereria bancrofti, which causes elephantiasis. The larvae are transmitted by a female mosquito bite.
And where do the adult worms go?
The adult worms take up residence in the lymph nodes, and they obstruct lymphatic flow.
And that obstruction is what causes the swelling.
It leads to chronic, massive swelling lymphedema in the limbs and hydrocele, which is scrotal swelling.
And there's a trick to diagnosing it.
There is. The microfilariae, the offspring, only circulate in the bloodstream at night. So blood samples for diagnosis are typically drawn after midnight.
And the famous river blindness.
This is Onchus circovolvulus, or Onchus cerciasis. It's transmitted by the bite of the female black fly, which, as the name suggests, lives near rivers.
And where do these larvae mature?
The larvae form subcutaneous nodules, where they mature into adults. But it is the microfilariae, the baby worms, that migrate through the tissues.
And when they reach the eye?
When they reach the eye, they cause chronic inflammation, intense itching, and ultimately irreversible blindness. Ivermectin is highly effective at killing the microfilariae, which can halt the progression of blindness if given in time.
So we circle back now to fungi to cover the systemic infections that define specific geographic regions. Let's start with blastomycosis.
Blastomyces dermatitis is one of the classic systemic mycoses endemic to North America.
Specifically the Mississippi and Ohio River valleys.
That's his home turf. And we noted earlier how these are dimorphic fungi.
Meaning they have two forms.
Exactly. They exist as a mold in the environment, in the cold soil, and then they switch to a distinct yeast form at body temperature, 37 degrees Celsius.
And the yeast form has a particular look.
It does. It's characterized by its large size and its broad-based budding structure. It's a key identifier.
How does blastomycosis differentiate itself clinically from other systemic fungi like histo or coccidio?
Clinically, while it can cause a pneumonia that mimics tuberculosis, blastomycosis often manifests with distinctive pimple-like skin lesions.
So we should keep the geographical contrast clear.
We should. Histoplasmosis is also in the river valleys, but it's associated with bird and bat droppings. Coccidioidomycosis, on the other hand, is one found in the desert southwest U.S., often causing desert bumps.
And the treatment for systemic blastomycosis?
It's treated with itraconazole, or, if it's severe, our old friend amphotericin B.
Lastly, the ubiquitous Candida albicans.
Candida is usually part of our normal flora, but any disruption of the host environment allows for overgrowth.
So we see superficial infections pretty commonly.
Yes, things like vaginitis or oral thrush. But the real danger lies in systemic spread.
And which conditions are the biggest risk factors for that systemic candidiasis?
Any immunocompromised state is key. So uncontrolled diabetes, advanced AIDS, broad-spectrum antibiotic use, which kills off competing bacteria.
And there was one other major group mentioned.
Critically, intravenous drug users. They are highly prone to Candida endocarditis, which is an infection of the heart valves.
And the treatment choice is entirely based on location and severity.
Completely. Fluconazole is fine for superficial infections, but you need amphotericin B or high-dose fluconazole for life-threatening systemic infections.
That was an eye-opening journey through the eukaryotic threats. Now we dive into the prokaryotic world, where bacteria have mastered the art of chemical warfare. We're focusing heavily on the potent toxins they deploy.
Yes, and we begin with a disorder defined entirely by a toxin acting on the nerves, botulism.
Caused by Clostridium botulinum, a gram-positive, spore-forming anaerobic rod. We need to focus on how this preformed toxin causes such profound paralysis.
The botulinum toxin is a neurotoxin. It works specifically at the neuromuscular junction.
Where the nerve meets the muscle.
Exactly. It binds irreversibly and presynaptically, and it prevents the fusion of vesicles that contain acetylcholine, or HA.
And acetylcholine is the neurotransmitter required for the muscle to contract.
It is the go signal. By blocking its release, the toxin causes flaccid paralysis, a complete inability to contract the muscle.
So it's essentially cutting the transmission cable between the brain and the muscle, causing a complete power failure.
That's a perfect analogy.
And the clinical presentation is classically described as descending.
Exactly. The symptoms start rapidly, often within a day of consuming the toxin, which usually comes from improperly canned foods.
And the first nerves affected are the cranial nerves.
Yes. Blurred vision, dry mouth, loss of the gag reflex. The paralysis then descends systematically.
And without immediate treatment.
Without immediate antitoxin, the patient often needs ventilator support because the diaphragm muscle fails. And we should also mention, in infants, we see the ingestion of spores from honey leading to floppy baby syndrome.
Now contrast that flaccid paralysis with the mechanism of diphtheria. This is a toxin that attacks the machinery of the cell itself.
Right. Corynebacterium diphtheria produces an exotoxin that is a formidable inhibitor of protein synthesis.
And how does it achieve that?
It achieves this by chemically modifying, specifically by ADP ribosylating a key protein called elongation factor EF2.
And EF2 is absolutely essential for what?
For moving the ribosome along the mRNA strand during translation. So blocking it shuts down all protein synthesis in the cell, leading to rapid cell death.
What's the most alarming sign that immediately suggests diphtheria in a patient?
The gray pharyngeal pseudomembrane.
Tell us about that.
It's a dense, sticky layer of fibrin, dead cells and bacteria that adheres firmly to the back of the throat. And the sources stress that this membrane should never be scraped during an examination.
Why not?
Because of the high risk of massive bleeding and, more critically, sudden and severe airway obstruction.
Given the rapid damage from the toxin, what is the immediate treatment priority?
First and foremost is administering diphtheria antitoxin.
To mop up the circulating toxin.
Exactly, to neutralize any unbound toxin in the blood. Antibiotics like penicillin or erythromycin are secondary. They kill the bacteria, but they don't undo the damage already caused by the toxin.
And prevention, thankfully, is highly effective through the DTaP toxoid vaccine.
Yes.
Okay, moving from nerve and protein blockade, let's look at toxic shock syndrome, or TSS. This is defined by a unique immune mechanism involving something called a superantigen.
TSS is usually caused by Staphylococcus aureus, which produces the superantigen toxin, PSST1.
And S. aureus is a gram-positive coccus. We can distinguish it in the lab by
It being both catalase and coagulase positive.
So what exactly makes a superantigen super? How does it bypass the normal vetting process of the immune system?
Well, normally, an antigen needs to be processed into tiny fragments and formally presented by the major histocompatibility complex, or MAC molecule, to the T-cell receptor.
It's a very specific lock-and-key process.
A very specific and time-consuming process. Superantigens bypass this entirely. TSST1 binds directly and simultaneously to the outside of the T-cell receptor and the MAC molecule.
So it clamps them together without the key?
It hotwires them. It forces a massive, non-specific T-cell activation.
That sounds like throwing a switch on 1,000 T-cells simultaneously.
That's exactly what it is, and it causes an uncontrollable, massive systemic release of pro-inflammatory cytokines.
An immune storm.
An immune storm, yes.
Yes.
And that storm is what leads to the high fever, the hypotension or shock, and the characteristic diffuse desquamating rash.
Our next set of cases focuses on bacterial warfare in the gut, where toxins are often deployed to hijack the host's fluid regulation systems.
A perfect example of that is cholera, known for the visually distinct rice water stools.
Vibrio cholerae, a gram-negative curved motile rod, acquired from contaminated water.
Yes, and the mechanism is a textbook example of toxin-mediated secretory diarrhea. The cholera toxin targets the host cells, and it ADP ribosylates adenyl cyclase.
Okay, so what's the downstream consequence of that chemical modification?
It permanently activates adenyl cyclase. This causes the constitutive, irreversible production of high levels of cyclic AMP or KMP inside the cells lining the gut.
An elevated CMP does what?
It forces the massive unregulated secretion of chloride ions into the gut lumen, and water and other electrolytes follow passively.
The fluid loss is staggering. The sources say up to 1 liter per hour.
It is. It leads to rapid, severe dehydration, hypokalemia, and metabolic acidosis. This is why, critically, the first-line treatment is not an antibiotic.
It's rehydration.
The primary intervention, the one that saves lives, is prompt oral rehydration solution, ORS, to replenish the lost fluids and electrolytes. Antibiotics like doxycycline are supportive. They shorten the duration, but they can't replace the lost fluid volume fast enough.
Contrast that rapid secretory diarrhea with the disruptive inflammatory diarrhea caused by C. difficile colitis, often seen in a hospital setting.
Clostridium difficile is a gram-positive, spore-forming anaerobe. The major risk factor is the disruption of the normal gut flora following antibiotic use.
especially penicillins, cephalosporins, and clindamycin.
Those are the big three. Killing off the competition allows C. diff to colonize and produce its powerful toxins, toxin A and toxin B.
And what visible damage do those toxins cause in the colon?
They lead to widespread mucosal damage, severe inflammation, and the formation of characteristic yellowish raised plaques or pseudomembranes on the colon lining.
Which can be fatal.
It can be if it progresses to toxic megacolon or perforation. Treatment involves oral antibiotics, specifically oral vancomycin or metronidazole, to target the bacteria where they reside in the gut.
And the sources mention the emerging role of fecal transplant.
Yes, for patients with recurrent C. diff infection where antibiotics repeatedly fail to restore balance, a fecal microbiota transplant, or FMT, is increasingly standard.
And it works
By reintroducing a robust, diverse community of healthy bacteria to outcompete the C. difficile spores and restore resistance to colonization. It has remarkably high success rates.
Our final GI pathogen is enterohemorrhagic E. coli, or EHEC, the agent behind hemolytic uremic syndrome, HUS.
EHC 0157, H7 is often acquired from contaminated ground meat or vegetables. It produces the Shiga toxin, or Shiga-like toxin, which is devastating because of its systemic reach.
And how does the Shiga toxin shut down cellular function?
It is another potent protein synthesis inhibitor. The toxin binds to the 60S ribosomal subunit inside the host cell, and it cleaves a specific glycosidic bond.
Halting all protein production.
Immediately. And while this affects many tissues, the primary target that defines HUS is the renal vascular endothelium, the lining of the blood vessels in the kidney.
And the resulting triad of HUS is?
Damage to the kidney blood vessels causes three things. First, microangiopathic hemolytic anemia, where red blood cells are mechanically sheared by the damaged vessels. Second, thrombocytopenia, because platelets are consumed trying to patch the damage. And third, acute kidney failure. This is a pediatric emergency where supportive care, including dialysis, is paramount.
We now look at bacteria that have developed mechanisms not just to release a toxin, but to survive long-term inside the host's own cells, making them much harder for the immune system to eradicate.
A perfect example is Legionella pneumophila, the cause of Legionnaire's disease. It's an atypical pneumonia often acquired from environmental systems.
Right, Legionella is a gram-negative rod whose key risk factors involve aerosolized water exposure.
The cooling towers, air conditioning systems, large plumbing systems,
And host vulnerability.
particularly smoking and COPD.
Its ability to hide inside our cells dictates the entire treatment approach.
Absolutely. Legionella is a facultative intracellular organism. It infects and survives inside our alveolar macrophages. It means that antibiotics that work primarily outside the cell, like the ubiquitous beta-lactams, the penicillins, are totally useless against it.
So you need a drug that can get inside the cell.
You must use drugs that penetrate the host cell and accumulate inside the macrophage. Things like the macrolides, erythromycin, or tetracyclines.
Case 32 introduces us to Listeria monocytogenes, a major concern for pregnant women and newborns.
Listeria is a gram-positive rod, famous for its characteristic tumbling end-over-end motility under a microscope.
And transmission occurs when a pregnant woman ingests the bacteria.
Often from unpasteurized dairy products like soft cheeses or from deli meats. This can lead to severe meningitis in the newborn or even fetal demise.
So how does it manage to bypass the immune response in the mother and get to the fetus?
Listeria is an extremely savvy intracellular hider. It uses specialized proteins called ACTA to hijack the host cell's cytoskeleton.
It's internal scaffolding.
Exactly. This allows the bacteria to literally push itself from one host cell directly into an adjacent one without ever having to expose itself to the antibodies in the bloodstream.
It moves by rocketing through the cytoplasm.
A perfect description.
Next, we must spend time on tuberculosis. TB, the oldest and most persistent intracellular threat.
Mycobacterium tuberculosis is defined by its cell wall, which contains very high amounts of mycolic acid.
And because of this waxy coat,
It resists the standard gram stain. It has to be identified using the Diel-Nielsen or acid-fast stain.
we need to nail the distinction between primary and secondary TB lesions. Where do they appear?
Primary TB is the initial infection. It usually causes a self-limiting lesion called a Gond focus, often located in the lower lobes of the lung, accompanied by swollen ilar lymph nodes.
But secondary or reactivation TB is different.
Very different. It occurs years later, typically when the host becomes immunosuppressed. Reactivation is characterized by destructive, highly infectious cavitary lesions.
And these are located specifically in the upper lobes of the lung.
Yes, because that's where there is the highest oxygen tension, which is perfect for this highly aerobic bacteria.
And the treatment, RIPE, is infamous for its side effects, yet indispensable.
The standard treatment is 6 months of the 4-drug combination: rifampin, isoniazid, pyrazinamide, and ethambutol.
The side effects are essential knowledge. Let's go through them.
Rifampin causes all body fluids, sweat, tears, urine, to turn a vibrant red-orange color. The Gatorade drug effect.
And isoniazid.
Isoniazid often causes peripheral neuropathies. This must be prevented by co-administering vitamin B6 or pyridoxine.
Related to TB, Case 31 covers leprosy, or Hansen's disease.
Mycobacterium leprae is another mycobacterium, but it's unique because it is an obligate intracellular bacillus that grows best in cooler body temperatures.
Which explains the disease manifestation.
Exactly. That's why the disease is concentrated in the skin, the peripheral nerves, and the upper respiratory tract.
The source material draws a deep immunological line, differentiating two forms of the disease based on the host response.
This is a classic test of the host immune system. On one side, you have tuberculoid leprosy.
This occurs when the patient mounts a strong cell-mediated immunity, or CMI, response.
The T-cell army is active. This contains the infection, resulting in localized lesions, often with anesthesia, and a good prognosis.
And the other side of the coin?
Lepromatous leprosy. This occurs when the CMI is weak. The T-cells fail, leading to a massive bacterial load, extensive nodular skin lesions, and a much worse disseminated prognosis. Treatment requires long-term combination therapy, usually dapsone, rifampin, and clofazimine.
Next, we group two unusual bacteria that constantly trick microbiologists because they look exactly like fungi: Nocardia and Actinomyces.
Yes, both are gram-positive rods with that characteristic branching filamentous structure, giving them a fungal appearance.
So how can we possibly tell them apart in a clinical setting?
3 simple laboratory criteria are usually required. First, their oxygen requirement.
Okay.
Actinomyces is strictly anaerobic. It's typically found in the mouth or the GI tract. Nocardia is strictly aerobic, and it's often found in the soil.
What's the second differentiator?
The acid-fast stain. Nocardia is weakly acid-fast, while actinomyces is not.
And third, the patient population is a big clue.
A huge clue. Nocardia is a classic opportunistic pathogen. It causes pulmonary and CNS abscesses almost exclusively in the immunocompromised. Actinomyces, on the other hand, causes abscesses with sulfur granules following trauma in otherwise healthy people.
And their completely different treatment protocols reflect these fundamental differences.
Absolutely. Since they are fundamentally different bacteria, you use different antibiotics.
Yeah.
Nocardia is treated with the broad-spectrum trimethoprim sulfonidoxazole TMPSMX,
While Actinomyces is treated with
good old-fashioned penicillin G.
Case 21 involves septic arthritis, specifically caused by Neisseria gonorrhoeae.
And gonorrhea is a fastidious gram-negative kidney-shaped diplococcus. When it causes septic arthritis, it typically results in a monoarticular infection, so one painful, swollen joint.
And the diagnosis relies on analyzing the joint fluid.
It does. And the source material notes that a white blood cell count greater than 100,000 cells per cubic millimeter in the synovial fluid is a definitive sign of acute bacterial septic arthritis.
And the treatment always involves covering a co-infection risk.
Always. Because gonorrhea and chlamydia trachomatis, the leading cause of bacterial STIs, frequently coexist, treatment must cover both.
So, ceftriaxone for the N-gonorrhoeae.
And azithromycin or doxycycline for the chlamydia. Untreated infections can lead to severe chronic complications like pelvic inflammatory disease or PID and ectopic pregnancy due to scarring of the fallopian tubes.
Moving on to case 42, osteomyelitis, a serious bone infection.
Osteomyelitis is dominated by a single organism, Staphylococcus aureus. It accounts for about 90% of all cases.
And the risk factors are things like trauma, diabetes, IV drug use.
Yes, and S. aureus is uniquely equipped with surface proteins that allow it to adhere very strongly to the bone matrix.
But there's a crucial exception involving a specific host pathology that every medical student is taught.
The crucial connection is sickle cell disease.
Right.
Patients with sickle cell have compromised spleenic function and vascular damage that reduces their immune clearance of certain pathogens.
So they're at a much higher risk of developing
Salmonella osteomyelitis. So that must be considered in the differential diagnosis for these patients, even though S. aureus is the general rule for everyone else.
Finally, we arrive at Pseudomonas aeruginosa, the opportunistic threat in cystic fibrosis, or CF.
Pseudomonas is a classic gram-negative aerobic rod known for its environmental ubiquity and its opportunistic nature. It loves to infect burn victims, patients with indwelling catheters, and those on ventilators.
But why is it such a particular nemesis for CF patients specifically?
CF patients have a genetic defect that causes their mucus secretions to be abnormally thick and sticky. This mucus provides a perfect, sheltered, anaerobic microenvironment,
A breeding ground.
the perfect breeding ground. Pseudomonas colonizes this thick layer and forms massive biofilms.
And those biofilms are like a shield.
Exactly. The immune system and antibiotics cannot penetrate them easily. This results in a chronic, destructive inflammatory state that eventually obliterates lung function.
The organism is also highly virulent due to its toxins and structural factors.
Yes. It possesses pili, endotoxin, or LPS, and key secreted toxins like exotoxin A and S.
And it's often multi-drug resistant.
Very often. Treatment requires aggressive combination therapy, utilizing multiple agents like specific anti-pseudomonas penicillins, piperacillin aminoglycosides, and specific cephalosporins.
Now we delve into the world of viruses, defined by their minimal genomes and their need to completely commandeer our cellular machinery to reproduce.
Yes, and we begin with two highly contagious childhood illnesses that define the importance of vaccination. Case 36, measles or rubeola.
Measles is an RNA virus from the morbillivirus family. Highly transmissible. The clinical line is crucial here.
It starts with the prodromal phase, high fever, malaise, and the famous 3 Cs.
Cough, conjunctivitis, and coryza.
Cough, red watery eyes, and a runny nose. Then, just before the full-body rash, we see the highly diagnostic but transient Koplik spots.
Tiny bluish-white lesions on the inside of the cheek.
Yes, on the buccal mucosa, they're a key sign.
And the rash itself has a distinctive spread pattern.
It does. It is a maculopapular rash that spreads cephalocaudally.
So, head to toe.
It starts behind the ears, on the face, and then moves down to the trunk and extremities. And while most cases resolve, the neurological sequelae are terrifying.
Beyond acute encephalitis.
Patients can develop subacute sclerosing panencephalitis, or SSPE, years later. It's a fatal progressive brain disorder.
Next, a less severe but highly common virus, hand-foot-mouth disease, caused by Coxsackie-A virus.
Coxsackie-A is part of the Picornaviridae family, a single-stranded RNA non-enveloped virus.
And it causes a syndrome defined by the tender vesicular rash.
Yes, found on the palms, soles, and buttocks, along with painful vesicles inside the mouth.
Do the other Coxsackie strains cause issues beyond just a rash?
They do. While Coxsackie-A is usually milder, the Group B strains are known to be far more invasive. They can cause severe diseases like myocarditis, which is inflammation of the heart muscle, pericarditis, and pleuritic pain.
Case 51 brings us to rotavirus, the primary cause of acute diarrhea in infants.
Rotavirus is the most common cause of acute watery diarrhea in U.S. children, especially during the winter months. It's transmitted via the fecal-oral route.
So explain how a virus causes such dramatic fluid loss.
The virus targets and replicates specifically in the villus cells of the proximal small intestine.
And those are the cells responsible for absorption.
Exactly. This replication destroys those cells. The resulting malabsorption, combined with some toxin-mediated secretion, leads to severe, non-bloody, watery diarrhea and dehydration.
And immunity in this young population is critical.
It is. Children under 6 months are often protected by passive immunity maternal IgA antibodies passed through breast milk.
But after that,
Beyond that age, vaccination is crucial, especially since the vaccine is a live, attenuated oral preparation that stimulates mucosal immunity right where it's needed.
finally, in this section, we confront the nearly universally fatal zoonotic threat, rabies.
Rabies is caused by a rhabdovirus, which is recognizable by its distinct bullet shape under an electron microscope.
Transmitted by the bite of mammals, bats, raccoons, skunks, foxes.
And if left untreated before the onset of symptoms, the mortality rate is essentially 100%.
The virus seems to have mastered nerve travel. How does it get from the bite site to the brain?
It is a master traveler. The virus binds to acetylcholine receptors on peripheral nerves and travels silently, retrogradely, moving backward up the axon toward the central nervous system.
And it has a preference for certain parts of the brain.
It does. It preferentially infects neurons in the hippocampus and the brainstem.
What's the microscopic calling card of the virus inside the brain? The thing you look for on autopsy.
The definitive diagnostic finding is the presence of Negri bodies.
And what are those?
They are unique eosinophilic cytoplasmic inclusions found within infected neurons, particularly in the hippocampus. It's the cellular gravestone of the infection.
And the clinical signs leading to the fatal encephalopathy?
The inflammation in the brainstem causes intense pharyngeal muscle spasms, especially when the patient attempts to swallow.
This pain is what leads to the classic sign of hydrophobia or fear of water.
Yes, and hypersalivation, and eventual behavioral changes and paralysis.
So the post-exposure treatment must be delivered immediately.
Immediately. It involves a dual approach. First, passive immunity, using human rabies, immune globulin, or HRIG.
Antibodies given directly into the wound for immediate protection.
Exactly. And that's combined with active immunization using the human diploid cell vaccine, a killed vaccine administered over several weeks to stimulate the patient's own immune response.
Moving to the highly successful family of herpes viruses, characterized by their ability to establish lifelong latency within the host.
Yes, and we have Case 24 covering herpes simplex virus 2, HSV2, and Case 54 on varicella zoster virus, or VZV. Where do these DNA viruses hide?
They go dormant somewhere in the nervous system.
They do. HSV1, HSV2, and VZV all establish a latent infection in the dorsal root ganglia, the nerve roots branching off the spinal cord.
So they can lie dormant for years.
For years, yes, only to be reactivated by stress or immunosuppression, traveling back down the peripheral nerve to cause recurrent painful lesions, cold sores, genital sores, or shingles.
The treatment for the herpes family, acyclovir, is highly selective because it requires a specific viral tool for activation.
That's right. Acyclovir is a nucleoside analog that, once it's incorporated into the viral DNA chain, causes termination and inhibits the viral DNA polymerase.
But the trick is the activation.
The trick is the activation. Acyclovir must be phosphorylated. It needs a phosphate tag to become active. And this crucial initial step is performed by a viral-specific enzyme, thymidine kinase.
So if the virus mutates and loses that enzyme, the drug is completely useless.
Exactly. Without the viral thymidine kinase, our own host cells just ignore the drug. This selective activation mechanism is what minimizes toxicity to uninfected human cells.
Case 54, shingles or zoster, is the classic reactivation of VZV, the chickenpox virus.
Shingles is intensely painful. It presents as erythematous papules or vesicles distributed unilaterally along a single sensory nerve or dermatome.
So it doesn't cross the midline of the body.
It doesn't. For instance, reactivation along the ophthalmic division of the trigeminal nerve, V1, can cause severe eye damage.
This is a good moment to discuss the difference between the available vaccines.
We have live attenuated vaccines for VZV, so for chickenpox, and for zoster, for shingles.
And live attenuated vaccines are excellent because
they stimulate both the humoral or antibody response and the crucial cell-mediated T-cell immunity needed to control an intracellular virus.
But they come with a major contraindication.
They do. Because they are live replicating viruses, they are contraindicated in pregnancy and in severely immunocompromised individuals due to the remote risk of causing the disease they're meant to prevent.
Next, cytomegalovirus, or CMV, another herpes virus that poses a severe threat primarily to the very immunocompromised.
That's the key. CMV is typically asymptomatic in healthy adults, or it might cause a mild mono-like syndrome.
But it's also one of the torch's congenital infections.
It is, and it can cause profound defects like microcephaly and jaundice in newborns. However, in transplant patients and AIDS patients, it is devastating.
What's the defining complication of CMV in advanced AIDS patients?
CMV retinitis. It's an infection of the retina that leads to blindness. And this complication almost exclusively occurs when the CD4 plus T-cell count drops critically low, below 50 cells per cubic millimeter.
And the treatment?
The treatment ganciclovir is also a nucleoside analog requiring activation by a viral kinase, but it carries higher toxicity than aciclovir, often causing bone marrow suppression.
Now we move to the RNA fevers, starting with dengue, also known as breakbone fever.
Dengue is a single-stranded RNA virus in the Flaviviridae family. It is transmitted by the Aedes aegypti mosquito, a diurnal species that thrives in urban areas.
And the name breakbone fever refers to
the severe, agonizing joint and muscle pain that accompanies the high fever.
But the real danger lies in the possibility of dengue hemorrhagic fever, DHF. And the key to understanding that risk is a unique immunological concept.
Yes, the mechanism is called antibody-dependent enhancement, or AD.
How does that work?
Dengue has 4 distinct serotypes. If you are infected once, you develop a protective immune response to that specific strain. But if you are subsequently infected a second time, with a different serotype.
But first infection doesn't help.
It makes it worse. The pre-existing non-neutralizing antibodies from the first infection bind to the new virus.
And instead of neutralizing it, they actually act as a Trojan horse?
Precisely. They enhance the uptake of the virus into host macrophages, leading to a massive accelerated viral load. This uncontrolled replication is what triggers the severe vascular permeability, hemorrhage, and shock that define DHF.
So past immunity actively worsens the current infection.
In this specific case, yes.
Case 60 is yellow fever, a cousin to dengue, also a flavirus, but with different end organ damage.
Yellow fever, endemic to South America and Africa, shares the mosquito vector.
Yeah.
But it targets the liver far more aggressively than dengue.
So what are the key differentiating clinical hallmarks?
Severe jaundice, which is where it gets its name, significant hemorrhage leading to black vomit, and severe renal damage. While both are dangerous, yellow fever has a much higher risk of multi-organ failure.
We turn now to viruses that highlight the global legacy of infectious disease and the constant evolutionary battle.
And poliomyelitis is a devastating example of a virus that targets specific parts of the nervous system.
Polio is a small, tough picornavirus, single-stranded RNA, non-enveloped, spread via the fecal-oral route.
And in a small fraction of cases, the virus enters the central nervous system via the bloodstream.
Walk us through exactly what part of the nervous system the virus attacks to cause that specific flaccid paralysis.
It selectively destroys the lower motor neurons.
And those are located in the anterior horn cells of the spinal cord.
Yes, these motor neurons are responsible for initiating muscle contraction. Their destruction results in the classic finding of flaccid paralysis, loss of muscle tone, and eventual wasting without affecting sensation.
The history of polio vaccination is a fascinating case study in public health strategy. The difference between the Salk and Sabin approaches.
It is. The Salk vaccine is killed or inactivated. It's injected, and it induces strong systemic IgG antibodies, which prevent the virus from ever reaching the CNS. It prevents paralysis, but it provides poor mucosal immunity. The recipient can still harbor and shed the virus in their gut.
And the Sabin vaccine?
The Sabin vaccine is live attenuated, administered orally. It provides excellent mucosal immunity and confers passive protection to household contacts herd immunity through virus shedding.
The major disadvantage being?
The major disadvantage is that extremely rarely the live vaccine can revert to a virulent strain and cause paralytic polio.
Case 26 brings us to influenza, the master of mutation, and the concepts of antigenic shift and drift. This is where understanding the virus's genome structure is critical.
Influenza is an orthomyxovirus. It is unique among RNA viruses because its genome is segmented. It's in 8 separate pieces.
And its key surface proteins are hemagglutinin, H, and neuraminidase, N.
And that segmented genome is what allows for dramatic, sudden changes.
So let's simplify the two evolutionary mechanisms. Shift versus drift.
Antigenic drift involves small, continuous point mutations in the H and N proteins. These minor changes are what allow the virus to slightly evade last season's antibodies.
And that's why we need a new flu shot every year.
Exactly. It causes the seasonal epidemics. Antigenic shift, on the other hand, is the catastrophic evolutionary jump.
How does that catastrophic jump happen?
It results from reassortment, the swapping of entire segmented RNA chunks. This happens when a human influenza strain and an animal strain, like bird or swine flu, co-infect the same cell.
And this creates an entirely new HN combination.
A combination like H1N1 that the entire human population has zero pre-existing immunity against. And that is what leads to pandemics.
And pharmacologically, how do we fight back?
Treatment often targets the neuraminidase enzyme. Neuraminidase inhibitors, like zanamivir and oseltamivir, block the enzyme that allows newly formed viruses to cleave away from the infected host cell membrane and spread.
But they have to be given quickly.
Very quickly, usually within 48 hours of symptom onset to be effective.
Moving to case 37, mononucleosis caused by Epstein-Barr virus, or EBV.
EBV, another herpes virus, causes infectious mononucleosis, characterized by profound fatigue, sore throat, fever, lymphadenopathy, and frequently splenomegaly. It's transmitted primarily via saliva.
The diagnostic finding here is less about the virus itself and more about the host's robust immune response to it.
That's a great way to put it. On a peripheral blood smear, we look for an increased total white blood cell count, but specifically an increase in lymphocytes. often over 50%.
Including at least 10% atypical lymphocytes.
Yes. And these are large, highly reactive T cells that are aggressively fighting the B cells that have been infected by the virus.
Beyond the acute syndrome, EBV has a notorious association with malignancies.
It does. It is strongly linked to two different cancers globally. Burkitt lymphoma, a B-cell lymphoma seen predominantly in African children,
And
esophageal carcinoma, which is common in southern China.
we end our pathogen survey with arguably the most bizarre infectious agent of all, Creutzfeldt-Jakob disease, CJD, caused by a prion.
CJD is a uniformly fatal prion disease. It's characterized by rapidly progressive dementia, ataxia, which is a lack of coordination, and myoclonus, or jerky movements.
And it inevitably leads to death within 1 year.
Within a year, yes.
What is the classic histology found in the brain tissue of CJD patients?
The pathology is defined as spongiform encephalopathy. The brain tissue exhibits neuronal loss and numerous vacuoles or holes in the gray matter.
Giving it a porous, sponge-like appearance.
Exactly.
And the agent itself completely defies the definition of life. It lacks any genetic material.
That's the core mystery. Prions are purely proteinaceous infectious particles. They do not contain RNA or DNA.
They're composed entirely
Of an abnormally folded protein, which we call PRPSC. The normal cellular prion protein, PRPC, has a helical structure. The pathogenic PRPSC misfolds into a beta-pleated sheet structure.
And that structure is highly stable and resistant to being broken down.
It is, and once it's misfolded, it acts as a template, forcing other normal proteins to misfold in the same catastrophic way.
It's a toxic, self-propagating cascade.
It is, a cascade of misfolding that leads to the accumulation of aggregates and neuronal death. And this extreme structural stability has enormous implications for infection control.
How so?
Prions are extremely hardy. They are not destroyed by standard autoclaving or routine decontamination methods, making transmission via contaminated CNS tissue in surgery a perpetual and terrifying risk.
Our final section shifts gears entirely, focusing on the immune system itself. We explore the consequences when the defense mechanisms fail completely, leading to susceptibility, or when they overreact, leading to severe pathology.
Right, and we start with a major failure of the first line of defense, phagocytic function in chronic granulomatous disease, or CGD.
CGD is an X-linked inherited immunodeficiency, leading to recurrent, life-threatening bacterial and fungal infections. The core defect is a faulty killing mechanism inside the neutrophils.
Specifically, the patients have reduced activity of the enzyme NADPH oxidase
And neutrophils rely on this enzyme, too.
to generate a massive burst of oxygen-free radicals, what we call reactive oxygen species, or ROS. This is necessary to effectively kill the pathogens they have just engulfed.
So without NADPH oxidase, they can engulf the bacteria, but they cannot destroy them.
Exactly. They're like a police officer who can arrest a criminal, but has no way to lock them in a cell.
So their primary vulnerability is to a specific class of bacteria that can fight back against the host's weakened defense.
Yes, they are exquisitely susceptible to catalase-positive organisms.
And catalase is an enzyme that breaks down hydrogen peroxide.
Right, so pathogens like Staphylococcus aureus, Aspergillus species, and Burkholderia cepacia use their own catalase to neutralize the few free radicals the host manages to produce,
Leaving the neutrophils completely defenseless.
and unable to clear the infection.
Case 44 involves pneumocystis jirovecii pneumonia, or PCP, the most famous opportunistic infection in AIDS.
Pneumocystis is a fungus or a yeast, though its classification has been debated for years. It is present everywhere, but it causes symptomatic pneumonia almost exclusively when the patient's T-cell-mediated immunity collapses.
Specifically, when the CD4 plus T cell count falls below 200 cells per cubic millimeter.
That is the magic number.
The radiological findings here are characteristic and must be remembered.
They are. They typically show a diffuse, hazy appearance across both lungs, which is described as ground glass, bilateral infiltrates on a chest X-ray.
And because this infection is so common and so severe in this population,
Prophylaxis is started the moment the CD4 count drops below 200. The drug of choice is trimethoprim sulfamethoxazole, or TMPSMX.
our final deficiency case is hereditary IgA deficiency, the most common blood product defect.
IgA is the primary antibody responsible for mucosal protection in the gut, lungs, and sinuses. Deficiency leads to recurrent sinopulmonary and GI infections.
But the massive acute risk is related to blood transfusions.
It is. If they receive a normal transfusion containing IgA, their system can go haywire.
Why is that?
Because they lack IgA, their bodies often develop circulating Ig antibodies. So if they're given normal blood products that contain IgA, their immune system recognizes that normal IgA as completely foreign,
Triggering.
triggering a massive, life-threatening anaphylactic transfusion reaction. Specialized IgA-depleted blood products must be used for these patients.
This neatly ties back to B-cell function. Briefly remind us how B-cells switch from making primitive IgM to making specialized IgA or IgG.
B cells initially produce low-affinity IgM antibodies, but after T cell help, specifically through CD40 ligand and receptor activation, they undergo what's called class switch recombination,
A genetic rearrangement.
a genetic rearrangement that allows the B cell to switch from producing IgM to producing the high-affinity specific antibodies needed for long-term protection, like IgG for the system or IgA for the mucosa.
Now we move to the flip side of immunodeficiency. The immune system overreacting, known as hypersensitivity reactions.
Right, and contact dermatitis from poison ivy is the classic example of a delayed reaction.
This is a textbook type IV hypersensitivity reaction.
And the key is that it is delayed, appearing 24 to 72 hours after exposure, and it is cell-mediated.
Meaning it's driven by T cells, not antibodies.
Exactly. It's T cells releasing inflammatory cytokines that cause the localized blistering and erythema. The PPD skin test for TB is another perfect example of this exact mechanism in action.
This is the perfect moment to pause and synthesize the 4 types of hypersensitivity reactions, as this framework is critical for understanding allergy and autoimmunity.
Yes, this table from the sources provides the essential quick reference guide. Let's run through them.
Type Y.
Type I, immediate, the fastest reaction. It's mediated by IgE antibodies binding to mast cells, triggering massive immediate histamine release. Think anaphylaxis from a peanut allergy or severe allergic asthma.
Okay, type 2.
Type 2, cytotoxic. This is mediated by Ig antibodies binding to cell surface proteins on the host's own cells. This marks the cell for destruction, either by complement activation or phagocytosis. Examples would be autoimmune hemolytic anemia or myasthenia gravis. Type 3, immune complex. This is mediated by specific antigen-antibody complexes that form in the blood and then deposit in vessel walls or tissues. This triggers complement activation and severe local inflammation. Think post-streptococcal glomerulonephritis.
And finally, the one we started with, type 4.
Type 4, delayed, the slow reaction. It's mediated by T cells and cytokines, causing tissue damage slowly over days. As we said, poison ivy or organ transplant rejection.
Speaking of rejection, Case 59 details the different timelines of immune attack against a transplanted organ.
The graft rejection mechanisms are highly time-dependent. Hyperacute rejection occurs within minutes.
Minutes.
Yes. It's caused by the recipient having preformed antibodies against the donor antigens, leading to immediate clotting and necrosis of the graft's blood vessels. The organ turns black on the table.
That is essentially a type 2 or type 3 reaction happening at lightning speed.
Exactly. Then you have acute rejection, which occurs within days to weeks. This is the classic cell-mediated attack by the host's T cells, recognizing the donor MHC molecules as foreign.
And this can be managed.
It can often be managed with aggressive immunosuppression, but it requires constant monitoring.
And finally, chronic rejection.
Chronic rejection occurs over years. It's characterized by slow fibrosis and gradual occlusion of the graft's blood vessels, leading to inevitable failure of the organ.
And the unique complication of bone marrow transplant, graft versus host disease, or GVHD.
GVHD is the inverse problem. In this case, it is the donor T cells, introduced via the transplant, that recognize the recipient's tissues, the skin, liver, GI tract as foreign, and launch a devastating attack. The host becomes the target.
We finish this massive deep dive with 2 cases that highlight the systemic reach of microbes, connecting infection to critical systems like the heart and the CNS.
Yes, and case 35 is Lyme carditis, demonstrating how a tick-borne infection can disrupt the heart's electrical system.
Lyme disease is caused by Borrelia burgdorferi, a gram-negative spirochete transmitted by the Ixodes tick.
And in its disseminated stage, the spirochete can invade the heart tissue, causing inflammation or carditis.
The dangerous clinical outcome of this inflammation is often seen on an ECG.
Yes, the carditis damages the heart's electrical conduction system. Most commonly, this results in progressive or complete heart block, frequently a third-degree atrioventricular block, or AV block.
Which means the electrical signal from the top of the heart isn't reaching the bottom.
Exactly. It blocks the signal from reaching the ventricles, causing severe bradycardia and syncope, or fainting. The treatment is urgent, requiring intravenous ceftriaxone until the conduction system recovers.
Finally, Case 40. Neisseria meningitis, one of the most feared causes of bacterial meningitis.
And meningitis is a gram-negative, kidney-shaped diplococcus that causes rapid, life-threatening systemic disease, particularly in young adults and children living in close quarters like dorms.
What structural components give this bacteria such high virulence?
The sources highlight four essential factors: PEPLE for initial attachment to the nasopharynx, IgA protease to destroy local antibodies,
Aphid capsule.
to protect against host defenses, and the powerful cell wall component, lipopolysaccharide or LPS endotoxin.
And when the bacteria are lyzed by the immune system or antibiotics, this LPS is released.
And it causes massive systemic shock and coagulation issues.
And what are the classic physical signs of meningeal irritation that demand immediate action?
The rapid onset of fever, vomiting, severe headache, and the presence of a non-blanching petechial rash are urgent indicators.
And on physical exam.
Clinicians look for the Koenig sign, which is painful resistance to straightening the leg when the hip is flexed, and the Brzezinski sign, which is involuntary hip and knee flexion when the neck is flexed.
Treatment is immediate.
Immediate empirical intravenous antibiotics like penicillin G or ceftriaxone, often combined with prophylaxis for close contacts to prevent spread.
What an astonishing survey of the microbial world and the host defense system. We've managed to distill the core mechanisms from 61 complex cases, emphasizing how vastly different life forms, from segmented RNA viruses that swap genomes, to intracellular bacteria that hijack the cytoskeleton, and even misfolded proteins that resist sterilization, all exploit specific vulnerabilities in our human biology.
If we connect this journey to the bigger picture, this collection of cases highlights the crucial dual nature of infectious threats that define global health. On one hand, you have the classic, highly virulent environmental pathogens like cholera, which relies on poor sanitation, or rabies and Chagas, which rely on animal or insect vectors. These are threats inextricably linked to infrastructure and climate.
But then you have the army of opportunistic pathogens that only exist because of the vulnerabilities we create for them. Pneumocystis, CMV, and Toxoplasma thrive when AIDS destroys our T cells. Aspergillus thrives when we use powerful immunosuppressive drugs. This duality means public health must always fight on two fronts: cleaning up the environment and bolstering the individual host defenses.
And understanding the core mechanism of action is the ultimate key to being well-informed. Knowing why metronidazole requires an anaerobic environment to work, or why acyclovir is safe for human cells because it relies on a specific viral enzyme, transforms a dry fact into applicable knowledge. The complexity demands continuous learning and a multi-perspective approach to pathology.
As we conclude this deep dive, we leave you with one final provocative thought to consider. Despite decades of unparalleled medical advancement, from vaccines to novel antibiotics, the sources show that many of the diseases that still cause the most widespread mortality and morbidity globally, such as rabies, cholera, dengue, and Chagas, still rely heavily on insect vectors, poor sanitation, or animal-to-human zoonotic transmission cycles. What stands out to you about the intersection between global health infrastructure, changing climate patterns, and the enduring prevalence of these ancient yet persistent organisms that cause the most suffering in the world?